We've had a complete revolution in melanoma treatment, more so than any other tumor group. When I started as a registrar in training, melanoma was essentially untreatable. We had dacarbazine and other chemotherapy regimes which didn't particularly improve survival, which had response rates in less than 10%. It was a very dire situation with median survival of between 6 and 12 months. And then over the last, less than 10 years, both in terms of emerging scientific principle, but then in terms of actually licensed drugs, we now have a plethora of agents at our disposal. So in particular, these sort of group into two main different types. They're the BRAF-directed therapies and then the immunotherapy agents. And the melanoma has now become the test bed, really, or the sort of poster child for this precision medicine and also for in terms of immunotherapy. So about 40 to 50% of all patients have mutations in BRAF, which is a very strong driver of outcomes for melanoma, and also because it's very easily targetable. Well, once targeted, patients respond almost invariably. So with combination BRAF-directed therapy, which includes both a BRAF inhibitor and a MEK inhibitor, we get response rates of over 70% and very good, PFS, progression-free survival, of 10 to 12 months. And this has been one of the revolutions. The other side of things in those patients who have no BRAF mutation or who have either progressed after BRAF-directed therapy, or where we feel that they have more indolent disease, we would target with immunotherapy. And this, as everyone has heard lately, is a really real change in paradigm. So our own CD8 cells, our lymphocytes, have an incredible precision and power to destroy cancer cells within the body, and they obviously can be activated to attack all different organs. And what's more, assuming you can engender memory, so you get the right T cells activated, they can keep on patrolling and keep the cancer at bay in perpetuity. This all happened in melanoma only in sort of 2011, when we had the licensing of ipilimumab compared to vaccination with GP100. And on the face of things, it wasn't a very dramatic response in terms of how many patients had actual shrinkage of the cancer and progression-free survival. But what really came out of that is there were about 20% of patients who had long-term survival, what we call the tail of the curve now. And that has been shown to be ongoing up to 10 years and beyond, with big pooled analyses that were subsequently put together. So we know that some of these patients are actually being cured of the disease, which is obviously a big change. And then with newer agents like PD-1 inhibitors and with combinations of PD-1 inhibitors and with ipilimumab, we've then shifted up responses, but also, in the absence of ipilimumab, reduced toxicity substantially. So now we've got these two major different groups. And another agent that's recently been licensed is TVEC as well, which is telimagene laherparepvec. And this is a HSV virus that has been engineered to only replicate within the cancer cells, but it also secretes a protein called GM-CSF. So essentially this leads to destruction of the cells within injected tumors. So just to say this is an injected treatment. It then leads to actually immune education within the melanoma metastasis, which these cells can then travel distantly and attack other metastases elsewhere. And we see within the studies that we can get responses in non-injected lesions and very substantial and durable overall responses despite not injecting all the lesions. So we've actually just presented a poster from the TVEC 325 study where we looked at, this was more a biomarker study. So we took biopsies of lesions at baseline, and then at week 6 after injecting the lesions, so these were non-injected lesions at week 6, to compare them to the lesions before injection at the beginning. And then we looked at the sort of density of CD8 cells within that. So our hypothesis was really to see whether we're seeing CD8, the T lymphocytes, infiltrating the distant metastases, and whether that was in any way corresponding with outcome. So the first thing we showed was that within the other uninjected lesions, we got a significant increase in CD8 cells of about 2.41-fold in median terms, and much higher in terms of the overall mean. And this is the first sort of demonstration of what we consider the likely mechanism of action of TVEC, of actually driving these CD8 cells into distant metastases. Now a lot of the concentration that we're working on now is to try and understand, which CD8 cells are in there, which ones indicate response and so forth. And so there's a lot of translational research that I think will give us a very strong clue as to how to use TVEC, but also how we can increase the efficacy by adding in drugs and how we combine those drugs.
And to bring this back to kind of the UK's perspective in modern melanoma treatment, you've seen and told us about all of these changes for patients in terms of the access and affordability of getting a hold of these drugs and seeing these benefits in their own lives. Do you have any thoughts and considerations in regards to that?
I think this is an evolving field, and actually overall we can access most treatments within the NHS. So the immunotherapy, including ipilimumab and nivolumab, is funded in the UK. We do have more constraints in terms of when the drugs can be used, in terms of sequencing and so on, and treatment after progression or re-challenge. But generally speaking, I think most of these drugs are readily available. We're just moving into the adjuvant setting, so using more of these drugs after a surgical complete resection. And this is, so we've got the first of those drugs come through, the dabrafenib and trametinib, which is now licensed and funded in the UK. But both nivolumab and pembrolizumab will likely be going through this process over the next few months. Nivolumab's initial application for funding hasn't been successful, but this is still an ongoing discussion. So I think overall we've got these drugs and they are making a real change in terms of patients' lives.
And you mentioned the role of surgery there for adjuvant, neoadjuvant treatments. How essential if the role of surgery remains in treating melanoma in the UK?
I think at the moment we don't want to detract, because we don't know yet. Most of these studies aren't comparing a direct, are not looking at removing surgery from treatment. There's quite a lot of interest in this Congress around neoadjuvant treatment, and I think that is evolving and potentially will in future lead to reduction in surgery. We do know from trials looking at the need for completion lymphadenectomy that we can actually not go ahead and just do a sentinel node biopsy, which is of prognostic purpose and which helps guide our subsequent therapy, but isn't really impacting on survival. But as it stands in terms of treatment of the primary, I think this would go as per standard procedures.
And I know this is in regards to melanoma treatment in the UK, but in your practice, have you seen any changing understandings from the public in the UK regarding melanoma, awareness of causes of skin cancers, different types of skin cancers, different behaviours to prevent them? Has any of that come through on a kind of a population level?
I think there is an evolving change, there is an evolution in that regard. But what I would say is that we don't often talk about that because I see patients who've already metastasized, and I don't particularly want to go backwards to discuss what could have happened. Because we're looking forward. I would say that there is an increased awareness, but probably not high enough. There's still quite high sunbed usage, for example, in the city I work in, Liverpool. And this is obviously something I would like to see reduced substantially.